Good afternoon, everyone. I am Sherry Ann Daniels, Executive Director of Papaolalokahi, and will serve as moderator for this session. Next slide. I wanted to provide you with a few housekeeping items before we get started. If you hold CHES or MCHES status and did not submit your ID number during registration, please submit your name and ID number to virtualsim_CEUs@minorityhealth.hhs.gov to receive your credits no later than tomorrow, September 18th, using the same email address used to register for the symposium. All virtual symposium attendees have been placed on mute. Please post your questions through the Q&A corner icon at the top of the screen for responses from the speakers. Due to the limited time, not all questions will be addressed during the symposium. Finally, we encourage you to answer the 2-question survey that will appear on your screen following this presentation. Next slide. It is my pleasure to introduce Gozi Ezeki. From the Illinois Department of Public Health, Dr. Ezeki was appointed by Governor J.B. Pritzker to serve as Director of the Illinois Department of Public Health in 2019. Prior to joining the Department of Public Health, Dr. Ezeki worked for over 15 years with Cook County Health, promoting the organization's mission of delivering integrated health services with dignity and respect, regardless of a patient's ability to pay. As a board-certified pediatrician and internist, Dr. Ezeki delivered inpatient care at Stroger Hospital, formerly known as Cook County Hospital, as well as primary and preventative care in community and school-based clinics. As the medical director for the Austin Health Center, located on the west side of Chicago, she saw patients of all ages and engaged with the community through health initiatives involving obesity, diabetes, and breastfeeding. Dr. Megan Kiyomi-Inada is a research coordinator at Kokua-Kalihi Valley Comprehensive Family Services. Dr. Kiyomi-Inada has been with Kokua-Kalihi Valley KKV since 2007. Prior, she was the Training and Technical Assistant Director for the Pacific Islands Primary Care Association and a Community Health Educator for the University of Hawaii's Cancer Center. Since 2012, she has been a graduate research assistant for the University of Hawaii's Cancer Center, focused on exploratory research with Micronesian communities surrounding health communication, knowledge, and beliefs, as well as healthcare utilization. Ms. Puni Jackson is the program director at Ho'oulu'aina, part of Kokua-Kalihi Valley Comprehensive Family Services. A Native Hawaiian cultural practitioner, Ms. Jackson has led endeavors in Hawaiian cultural and Aina-based educational programming for over 18 years. She is an accomplished Kanaka Maoli artist known primarily for her large-scale painting and installation work, and has exhibited nationally and internationally. She has been instrumental in establishing Ho'oulu'aina as a healing refuge for the community and for Native Hawaiian cultural practitioners. Ms. Jackson is also a respected and experienced practitioner of La'au medicine and other traditional Native Hawaiian healing arts, including cultural practices around childbirth. Next slide. The objective of this ensuring cultural appropriateness and language access through community-based approaches is to highlight promising and effective community-centered approaches for COVID-19 response for our racial ethnic minority populations with a focus on cultural and linguistic appropriateness. So let's begin.
Hello, and I am so pleased to be here today to share the work that the Illinois Department of Public Health has been doing in response to COVID-19 in communities of color and low-income communities. I will speak on our COVID-19 mobile approach for community-based intervention. I will cover the following areas in my presentation. First, I want to give a quick overview of the establishment and structure of the COVID-19 equity team and its importance to the COVID response efforts. And then I'll talk about some community-based mobile testing activities led by the COVID-19 equity team. I will conclude by sharing some lessons learned. At the height of the COVID-19 pandemic, as we were hurrying to address the pandemic, it became clear that, like so many other disasters, minorities and low-income communities would be disproportionately impacted on all levels, from infections to death, to availability of life-saving resources and sustained impact by the virus. These would further widen the disparities in health and well-being for these communities. At IDPH, our mission is protecting the health and improving lives, and the Center for Minority Health Services has made its core mission to eliminate health disparities for Illinois' racial and ethnic minorities through capacity building, workforce development, strong health policies, and implementation of culturally and linguistically appropriate programs, making it appropriate for this office to lead the charge during this pandemic. The center developed a plan by which real-time information flows from impacted racial and ethnic low-income and vulnerable communities directly to the IDPH team responsible for the COVID-19 response for immediate action and/or follow-up and feedback. The nucleus of this bi-directional communication flow is the COVID-19 equity team, made up of state agency, advisory groups, and statewide community advisory groups. The chief for the Center for Minority Health Services oversees the equity team and participates in regular briefings and presentations with the IDPH incident command teams and works with other operational areas within IDPH and the governor's offices to share valuable recommendations. This slide shows the groups that were formed. In the interest of time, I won't go over these groups. At the start of the COVID-19 epidemic, we heard from many communities and organizations who voiced concerns regarding multiple issues that would impact COVID response in their communities. COVID was not affecting everyone in the same way. Communities of color were dying at greater rates, thereby exposing the social and structural inequities that we have known have long existed in these communities. If we are to successfully address these structural and institutional biases that have long contributed to inequities in health and health outcomes for racial and ethnic minorities, then the balance of power is important. We must draw from a diverse wealth of expertise from various cultural and professional backgrounds to be at the table. So how do we achieve that? Through a collective impact approach. As the data continues to tell us, racial and ethnic minorities need special consideration to mitigate the risk of COVID-19 due to special circumstances rooted in history. We also know that because they are not a homogeneous group, we need to highlight the unique needs and challenges of each group and have culturally and linguistically appropriate interventions in place to address such needs. A collective impact approach is designed to bring everyone to the table to ensure their community's voices are heard. IDPH's CMHS serves as the backbone entity with the key functions of guiding the strategy, supporting aligned activities, establishing shared measures, cultivating engagement, advancing policy, and mobilizing resources. Key responsibilities of the COVID-19 equity team are to serve as a liaison between IDPH and communities, identify emerging issues within communities of concern, and propose actionable recommendations to IDPH, amplify critical and unmet needs of the community to the IDPH leaders, provide timely updates and rapid response to emerging issues, track and update communities on responses and resolutions to recommendations as a way of building trust and being responsive to communities' concerns. As mentioned earlier, the goal of the COVID-19 equity team is to address inequities exacerbated by COVID-19 in communities of color and low-income communities. 9 different work groups were established based on needs identified by over 30 entities that signed up to be a part of the collaborative. All work groups serving under the COVID-19 equity team are focused on these 3 key priorities: ensuring testing is accessible, available, and adaptable to community needs; ensure the delivery of culturally and linguistically appropriate communication and intervention strategies; provide COVID-19 related guidance and recommendations that positively impact communities of color. In addressing the key priorities of the COVID-19 equity team as it relates to our mobile approach for community-based interventions, I want to outline some of the activities that were undertaken by the team. We work closely with the state's mobile pop-up testing team, respond to community testing location concerns, and recommend ideal testing locations, observe testing location operations, provide feedback and corrective action to the state testing team, provide recommendations for marketing the state sites, implemented a faith-based testing pilot in partnership with key community stakeholders, initiated mobile testing at migrant campsites and housing units, developed a seniors testing and influenza plan in partnership with the Department of Aging, continued to identify hotspots in underserved low-income communities, and facilitated access to testing in identified areas of need. I want to pause and recognize that the groundwork for IDPH's involvement and expertise in mobile outreach during this pandemic bears roots in the mid-2000s thanks to HHS. IDPH was awarded a 5-year grant from HHS's Office of Minority Health, which established a Wellness on Wheels initiative within the Center for Minority Health Services to ensure underserved, low-income, and rural communities had access to basic health screenings. 4 mobile units were purchased to service the needs of disadvantaged and hard-to-reach communities statewide. These units are not strangers to pandemics. They were utilized for H1N1 activities in 2009, wellness checkups at welcoming centers for immigrants, and vaccines for children. The program is now funded through the Illinois State General Revenue Fund and continues to provide access to care in low-income and disadvantaged communities. The mobile units are available for use by community-based organizations upon request. IDPH provides a driver and the vehicle free of charge to the community and partner with providers to bring requested services to the community event. In the next 2 slides, I want to share examples of mobile outreach conducted in partnership with the faith-based communities and our migrant workers. For this slide, I will highlight a 3-day event targeting 9 faith-based sites in underserved areas in the near west, near south, and south side of Chicago. Multiple churches combined efforts to promote and market the event and provide the venues for testing. IDPH provided test kits, PPE for testing providers. IDPH labs were used to process the results. The WOW units provided naloxone training and distributed kits at 2 site locations each day. A total of 168 kits were distributed. 9 FQHCs provided the COVID testing and used the opportunity to reach the medically uninsured and underinsured with information regarding their services, how they could establish medical homes through their FQHCs. Through a partnership with faith-based leaders, we were able to get ahead of the flu season and still offer COVID-19 testing. Over 2,500 individuals were served. Walgreens provided free influenza vaccines, and over 2,000 individuals received flu vaccines. Blue Cross Blue Shield of Illinois provided PPE for participants, including hand sanitizer and masks. Intimate partner violence and child abuse resource list developed by the equity team was distributed. With Americans required to stay at home during the COVID-19 pandemic, this has been a concern for families who experience domestic violence. According to the CDC, 1 out of 10 men have experienced some form of domestic abuse. In May, the equity team convened the Rural Work Group to begin addressing migrant worker needs. The team formed a collaborative of over 20 stakeholder organizations to assess needs and help organizations draft proposals, housing plans, and recommendations to address COVID-19 related testing, language barriers, and other safety concerns. The team worked with rural and migrant organizations to secure arrival schedules and locations of migrant camps and housing units to target for testing. Workers started arriving in June and the season ends in October. The team then established a partnership with an FQHC that was skilled in working with migrant populations to do statewide mobile testing via the WOW. IDPH provided PPE for mobile staff and test kits for FQHC and the use of the IDPH lab for testing the specimens. The testing team consisting of the FQHC and the WOW established relationships with employers and provided on-site education on infection control, quarantine and isolation, proper mask covering, and hand washing for staff and employers. The team also established relationships and protocols with local health departments at every county where testing was to occur for smooth referral and smooth handoff of clients needing treatment and follow-up care who were within their jurisdiction. Bilingual staff provided education in linguistic and culturally appropriate formats. Included printed materials and instructional videos on COVID-19 health concerns. Additional support and resources such as housing vouchers, food stipends, and daycare services were also provided by collaborating partners. Some of the benefits associated with this partnership with community-based partners and other state entities include fostering collaboration between IDPH, other governmental agencies, and multiple external partners around a common approach to community-based intervention. Also, the sharing of resources and the elimination of the duplication of efforts. It provided a forum for discussion, insight, and clarification of community-based needs to develop a common operational understanding and work towards both short and long-term equitable solutions of unmet needs. To build community trust, the community has direct pipeline to IDPH to request services and resources for their communities. And some of the challenges that were experienced include competing interests and obligations that can sometimes hamper the ability of partners to collaborate effectively within the working group. Establishing a clear line of communication and reporting between internal and external partners. Delayed response or inability by IDPH to provide immediate or satisfactory feedback can work to erode trust. Lack of a comprehensive community engagement plan can create a shift in priorities or yield low outcomes or unattainable goals. Again, these are the lessons learned and some of the challenges, and I thank you for the opportunity to present all of the work that was done.
Mahalo so much. Aloha. My name is Puni.
And I'm Megan.
And we're from Kokua Kalihi Valley. Kokua Kalihi Valley is a federally qualified health center, and we were founded 48 years ago. We were founded at a time when our aunties and elders in our community went door to door to try and find out what the community really needed. And questions were like, how are you? And what do you need? How can we help you? Were the founding questions of how Kokua Kalihi Valley started. Our mission, together we work toward healing, reconciliation, and the alleviation of suffering in Kalihi Valley by serving communities, families, and individuals through strong relationships that honor culture and foster health and harmony. Has never been more present. We have never left that mission, but the recent introduction of the coronavirus into our community has made us really dig deep into our own mission. And recently, we founded a new program, and this is our emergency response for community, particularly around the pandemic. And that emergency response is entitled Hui Hoaka. It's very much about identifying those ways that community can come together to support each other through difficult times, and focus also on abundance, that sense of abundance that comes in community through connection. Hui Hoaka is broken down into, as you can see on this next framework slide, into human resources, staff well-being, communication, safety protocols, and also making sure that our funding and procurement is in alignment with the needs of the community. But basically, once the pandemic started in Kalihi Valley, we all came together. Many of us were redeployed to do different things to respond to the emergency needs. And language access was one of the most important ways that we were able to support our community, whether that was from outreach and calling people and making sure that they were okay, to making sure that on our medical side through telehealth and that style of outreach and services, that we had not just language support but cultural support. We deployed a major food and household and cleaning supplies delivery system that went out into the community every single day, and we're still in the middle of that. In fact, I have to step away from that work to do this presentation right now, and so I'm excited to be able to be part of a nationwide network where we're paying attention to what the community truly needs.
Just to provide some background information, a recent study found that Pacific Islanders have a 10 times the infection rate of COVID compared to other ethnicities in Hawaii. So Pacific Islanders is in yellow here. And at this point, we know that this isn't because Pacific Islanders are not washing their hands or wearing masks, right? And therefore, this inequity that we see clearly on this graph cannot be solved with our status quo individualized public health messaging, right? Rather, we must look to the outer circles of our social ecological model, right? So we have to look at our organizations, our community, and our policies. Because, even though this disparity is delineated by race, because oftentimes that's how we talk about health in America, we believe that actually it should be looked at by community. One of our people we look to is Wendell Berry in his writing, and he shared that the smallest unit of health is not the individual but the community, right? This aligns with our indigenous framework of health, the idea that health is connection, right? Connection to place, to others, to past, present, and future, and to our best selves. And so in our community, many of our community members are disconnected to their homelands, some because of nuclear testing done on their waters and lands, right? And unfortunately, because of COVID, we have become disconnected to one another, or it asks us to stay apart from one another, right? And so these can be painful things for our community, and so the answer is trying to reconnect or uplift those connections. And so that's what Hui Hoaka really tried to do in every step of the way, is uplift connections. Everywhere from our deliveries, which was really physically going out into the community, because we knew that they couldn't come to the programs that we used to have at our clinic anymore, right? And so they were able to see the smiling faces of our delivery staff. They were able to say hello and connect that way. We uplifted connection in procurement by really looking at the foods that were familiar to our community members. We provided fresh produce as one of the items in our care packages, and our staff really tried to design each box by culture, right? And so they knew, our Filipino families like malunggay, and our Micronesian families like bananas, right? And so really trying to connect people to foods that comfort them and heal them. We also tried to uplift connection through our outreach. We did callings, like Puni said, and oftentimes in the beginning, we had a lot of elders say, "Thank you so much for calling me. I was worried that I'd be forgotten," right? And so we connected that way. We also tried to connect through our print media, and that was not only through the words and translation into different languages, but also through the images that are comforting and familiar to all of our community, right? Foods that are familiar, faces that look like our faces, words that comfort us. These are the things that we try to do.
And so those senses of connection that we were trying to make sure to have in place, that we've been doing that for 40-something years, making sure that all of our patients and community members have connection to their own doctors and healthcare within the 27 languages that we offer at our clinic. And as we did call outs to make sure that communities were safe, we had many elders sheltering at home. We had many business owners that were struggling to be able to make through. But that outreach in February and March and April became the foundation of relationship building that supported us when the large numbers of COVID cases increased, and when our community had difficulty navigating state support around quarantine and isolation, trying to understand the safety and stigma around testing. We had people, advocates that spoke all different kinds of languages. Not only were they able to deliver the services in language, but they actually belonged to the community that our community members and patients were coming from. And so it's really important as we look to our communication strategies that our community can not only hear or read in their own language, but also see the way that they look, all different kinds of faces, all different kinds of professions. Just this week, we recorded a PSA that will be on our television locally and throughout social media, but we recorded it in many, many dialects in 5 different languages. So each language had its own sub-dialect, and people with recognizable personalities and cultural backgrounds are speaking to the community that overwhelmingly does not have a trusting relationship with government communication. So it was important that our voice from Kokua Kalihi Valley was a community and a grassroots voice, and familiar faces, familiar language, familiar cultural navigation.
And so now we're going to go into kind of our lessons learned. And what we learned is what we already knew, right? That relationships matter. That especially when people are afraid, we need trusting relationships in order for people to be vulnerable and really connect to the care and resources they need, right? We learned that connection is health. There's a story up from one of our advocates. Quarantining was ending for one of her patients, and the patient called her at 8 o'clock at night, and she said, can you turn your FaceTime on? I want you to see my face, and I want to see your face, so that when this is all over and we're walking around in the community, we can say hi to each other, right? It's that deep connection that was healing. We also found that systematic change requires enduring communication, right? We continue to meet with individuals in Department of Health and other organizations, building those relationships because we know that systems are slow to change, but that individuals within those systems can move quickly, right? And so oftentimes, we try to go through the system to connect someone to care and it didn't work. But if we called on those relationships that we built, we could make things happen. Also, agency lives in community. This is the idea that our community has agency. They have power within themselves. We saw this time and time again. We saw it when we would go out and deliver food to a homeless individual, and they said, actually, no, I don't need this, but I do know a family that needs help, and they would connect us to that family, right? We would see time and time again neighbors taking care of elderly individuals who didn't have other family members, right? So health was not being distributed by our organization, but we were just a part of this system that was holding each other up, right? And the last one is health is membership. Again, we're quoting Wendell Berry that health is membership, right? And what we believe is what creates membership is kokua or helping. So often we would go into the community and they would say, oh, I am kokua, I'm kalihi for life, right? And that was really important.
So this sense of kokua, which is our name, it's who we are. It means to help, but it means everyone coming together to help. And when the Office of Minority Health reached out to us and asked us to share a technique, a practice, a best practice that could be shared through other communities, this sense of kokua, of really building relationship, of caring about each other, and basically aloha. That is the technique that we hope that others listening to this presentation can take away with them, that it really matters that you know each other. It really matters that you care about each other. It really matters that that your connection to health is related to land, is related to culture, and that your offering of a service is a service that you would want offered to your own grandparents, to your own parents, because we are part of our community. We're not coming into a community to offer something from the outside. We are creating it from the inside. And in this image here, we can see Kaiulani Odom, who serves produces our organic food hub here in the Kalihi Valley. And the amount of produce through this process to be able to get out into the community has changed from 500 pounds of local organic produce per week to 7,000 pounds. Now that is aloha, that sense of connection, that sense of lifting up one another, that sense of making sure that without being asked, without being mandated, we're not going to just say that's not our job. We live with aloha, we serve with aloha, we're connecting to one another with aloha.
And I think some takeaways is the idea that anyone can do this, right? And you can do it through continuing to build relationships, right? Investing in the ones that you have and looking around and seeing where are you missing some relationships and really making the effort to go out into different organizations and find those.
And we've been having that sense of coming together. We might be a FQHC and we're showing up with doctors and public testing opportunities and telehealth and, delivering pulse oximeters to people's homes in housing projects, helping people access hotel isolation. But every single person, even the person who is just growing some bananas in their front yard, every person who can listen and really hear a story can be part of that network. And I think that we've isolated or separated the sense of medical care from community care, and I'm very proud to be part of KKV, where we are part of the community and medical care is part of our social determinants of health outreach. This quote, in the true essence of why KKV started, people are being reminded that we are descendants of those super aunties that went door to door. This is our genealogy. In the Pacific Island communities, we talk about genealogy, ancestors, and as a foundation of our understanding of health and connection. Well, our organization and our community also has a genealogy, and we look to those aunties that are seen here in the black and white in the center and building out around them the sense of abundance that is part of this community. That's our legacy that we are trying to perpetuate. That's our genealogy for this organization and this valley. And we're finding that that connection is what has made us prepared to be able to respond to the urgency of now. Thank you. Thank you so much for your time.